Good afternoon. My name is Agnès Soucat and I'm the Director for Health Systems, Governance and Financing at the World Health Organization in Geneva. And I'm sorry I cannot be with you today in person, but I hope you're enjoying this terrific conference and having a great time exchanging between colleagues about the future of hospitals and the importance of hospitals. Today, I would like to talk to you about universal health coverage and how, together as the global community, we are planning to go about it. As you may know, last September at the UN General Assembly, all countries gathered in the high-level meeting on universal health coverage, and they adopted what is probably the most comprehensive and ambitious declaration on universal health coverage that ever was adopted by the United Nations. And this declaration was anchored in an analysis that is included in this report of the World Health Organization, which is the Global Monitoring Report on Universal Health Coverage for 2019. And the title of the report is Primary Health Care on the Road to Universal Health Coverage. The adoption of the Declaration on Universal Health Coverage is looking to accelerate efforts of countries towards achieving this ambitious goal of access to health services to all by 2030 without financial hardship. So there is 10 years between where we stand today and our objective, 10 years where we need to accelerate our efforts to reach the unreached and particularly reach the ones left behind and achieve our goals of equity, quality, and efficiency. What does the report say that can help us focus our efforts and make them more efficient, both at global, regional, and country level? What we see is the world has made tremendous progress on health between particularly 2000 and 2017, which this report looks at. We see that generally all countries have made progress and indicators on health have improved, particularly access to services that prevent and treat communicable disease. This progress, however, has started to slow down between 2010 and 2015, where the rate of progress is lower than between 2000 and 2010. So we need to accelerate again. Moreover, we see that the progress that was achieved between 2000 and 2017 was achieved at an important cost to people. In fact, both catastrophic expenditures, which is large level of spending on health by people out of pocket, and impoverishing expenditures, that is bringing people, health expenditures bringing people under the poverty line, have increased over the period. In fact, what is happening is as countries get richer, people want more health care. And they get it by providing market signals. So providers developed, private sector developed, and people start paying more. But the public sector takes more time to adjust to this increased demand. And we see that it takes more time for public spending to react and respond to this increased demand from people. So what we see also is that there are drivers, economic drivers, social drivers of this progress that will need to be addressed if we want to scale up our efforts. One is we see that gender matters tremendously. We see that still there is an unfinished agenda on maternal and reproductive health. So we really need to look at the pockets, the countries, the regions in which still maternal mortality is high because of lack of access to emergency obstetrical care, for example. Also, regions or countries where child mortality is still high, and we still see that there is a remaining avoidable deaths of children in a couple of countries in which this effort needs to be accelerated. But gender matters also when it comes to men. While we see this unfinished agenda around reproductive health and the health of women, we also see a growing agenda on the health of men, and particularly poor men, around the use of tobacco, alcohol, the health ailments that are related to violence and what is often referred to as toxic masculinity. So the fact that we have in many countries a lower life expectancy and lower access to services for men, and particularly poor men, is also an obstacle to making more progress on universal health coverage. Inequities is what we need to tackle. Systematically, we see that the difference between rich and poor countries now is less than the difference within countries in terms of access to services. And the largest number of people not having access to services is actually in middle-income countries, and it is poor people who don't have access to health services. So what to do about this? What this report argues is that we need to focus the public action, and particularly public spending, on what makes a difference to the life of people, and particularly to reach the unreached and to reach the segments of population who don't have access to services. What does it mean? Well, that money will be less an issue than in the past. Many countries have moved from low income to middle income, or from middle income to high income over the past 20 years. And now there is only 35 countries who really are at low income status or fragility status and need large amounts of investments coming from development assistance. What we see is most countries now have some fiscal space they can use to invest in getting the last mile to become the first mile, and invest in access to services to the poorest segments of the population. And according to WHO, to our calculations, access to primary health care would cost about 200 billion a year, and access to a larger package of services would cost about 300 to 400 billion a year, which is much more than the close to 20 billion a year of development assistance, but would be largely covered by the economic growth and expansion of fiscal space through taxation in middle-income countries. So scaling up about 143 interventions if we talk just about primary health care, or 188 if we talk about a larger package that includes treatments of cancers and access to hospital care, would actually be possible in most countries. And the role of development aid is critical for leveraging these efforts in low-income countries. So if it is technically possible, and if it is financially possible, because we see that health expenditures are increasing faster than the economy, then what are we left for? We're left for with political and policy decisions. So reaching universal health coverage is really about those decisions. It's about political action. It's about good policies. It's about tackling the economic and social determinants. It's about understanding inequalities, understanding the barriers to access to health services, developing protection mechanisms, social protection, insurance mechanism, public financing mechanism that will help subsidize the access to services to the poorest segments of society. These are really the lessons learned from what has happened over the past decades, and we are at a crossroad. We need to change the scale. We need to invest in health systems development. We need to invest in access to a broad package of primary health care that includes access to critical hospital services. And this requires public action. This requires public regulation, legislative action, a set of actions strengthening the governance of health system, particularly around pooling resources and developing the strategic purchasing function for buying the right services for the right people. So what is the main message that I would like to leave with you is really that the agenda for the next 10 years is going to be an institution agenda. It's about strengthening institution. It's about strengthening the collective voice of people so that they decide what the collective purse is going to finance, whether it is about primary health care or hospital services. It will be about political choices. Thank you.